And so as Professor Cherney was saying, I'll try to be very short, and I'm sure you're really exhausted. This is must have been a very heavy day. The only good thing is that it's been raining outside all the time, so you're not missing any special opportunities outside here. So I'll try to present very quickly one of the projects we got funded recently that is related to early intervention, because we are very interested in early intervention in babies, so we try to develop some new tools that are actually trying to improve the quality of life of these babies. And in particular, it is called the Visible Project. I'll try to keep it short so that at the end, if you want, we can have a few minutes of questions and discussion. This project follow the flow that every project tries to follow. So from the idea to the proposal to getting awarded some fundings and then actually doing the project. And at the moment we are at this point here, so we are actually starting the recruitment. So the idea, of course, as you learned today and as you already know probably, is very important because it needs to come from some real needs from patients and families, especially in our field of neurorehabilitation. And so we, and you can have this starting idea basically. Usually it stems from your clinical activity or your interests in disorders, and in particular in our case, we have been working with babies for 20 years now, even more than 20 years, and so we really have been struggling trying to find ways to help these babies to have a better outcome. And indeed, it is to be a problem that has some weight overall, and if we look at this Lancet review paper where all the newborns that had some problems at birth, could be minor or more extensive or more severe problems, and they just pulled together all the studies studying babies, newborns with problems and assessing their outcomes. And as you can see here, at least 1/3 of these babies have some problems in the outcome. So certainly we know that these populations of babies at risk that have these red flags when they're born are really interesting, and it is important to target those. And we also know that it is very important for us to have an early start of our intervention, because otherwise we're going to miss a very important window of opportunity, that is the early phase of development when all the major systems have their highest levels of plasticity. And the problem with babies at risk is that for too long, the time of diagnosis and the time of detection of problems has been too late. This is out of frame. This should be not after 24 months. Currently, the diagnosis of cerebral palsy sits around 12 to 18 months, but it's really very late for us to be able to intervene. And so we have to push this back a lot in order to have the opportunity to start intervention. And so this is basically one of the ideas that came to our mind when we started this project, and the projects. So the early detection, we need to detect early, to find reliable tools to detect early our babies. And this is particularly important because if you look at the battery is, if you look at my battery is almost, and yours too, I guess.
This is your battery,
okay.
I think. Oh no, you don't, this is your, oh, this is mine. You have to put it in the...
Oh, okay, yeah, sorry.
And to put it
Great.
in the electricity.
Yeah, that's quite a universal.
Yeah.
No. Okay. So if we look at all the studies that have tried to target early intervention, we can see that the main problem is that often the risks that was assessed when the babies were recruited was not really that high. So if we think, for example, of cerebral palsy, most of the studies that try to target populations at risk when they were very young were based on moderate risk, like, for example, having a preterm birth or any type of asphyxia. So the problem in these type of studies is that when then you ended your study, more than half usually of your population didn't actually develop cerebral palsy. And this was irrespective of the treatment. So in some ways, the population was very diluted in terms of problems. And so it was harder to assess what the intervention can actually do because the selection was not very precise. And so for this particular study, we used all the knowledge we learned in developing the guidelines for early detection of cerebral palsy that have been published a couple of years ago with Iona Novak and many other collaborators. So we used that to select patients in our study, as we will see in a minute. So the problem is real, is frequent. It affects families and infants. It is possible to detect it very early. So we have all the ingredients to start an intervention, but then we have to decide what type of intervention. And again, since there are not many studies that are done on early intervention that are done in populations that are very, very high risk, like the one that we are trying to target, then we have to kind of look at the literature in a more general way and see what are the principles that neuroscientists share in terms of what is good for babies in terms of intervention, what are the ingredients that we need to have in our early intervention projects in order to be more confident that we are actually changing the natural histories of these babies. And so if we look at these principles, certainly there is a when of early intervention, and we have to act early because we have higher neuroplasticity. We said that already. And then there are a lot of hows of early intervention. We know that intervention activities needs to be variable, salient, fun for the baby. I'm sure you talked about this today. They have to be goal-directed. Motor learning is the principle of kind of changing the brain. Passive activities are not really impacting on the connectome of our brains. And of course, we have to target not only the baby, but the family. And this is a key aspect that you covered today extensively. And also the dose needs to be the right dose, so you need some intensity in order for the brain to be changed, actually, so plasticity to act. And of course, this is a very important aspect that needs to be kind of integrated with the previous aspects. For example, the variability and the acceptability, the tolerance of the baby. So the intensity is certainly too much when it starts to affect the availability of the baby. And also the where is very important for early intervention. And this is probably something that still is not as much evidence as all the other principles, but in which we believe very much. And we think that, especially in the first weeks and months of life, the where of early intervention is actually the space, the intersubjective space, so the space between the caregiver and the baby. And I'll try to tell you a few words about why we think that. To make a very long story very short, we really think that the driver of early development is the interaction between baby and caregiver. This is not only an ideal situation for the environment of the baby, but it's really a driver of cognitive development and motor development and sensory development, because we strongly believe that in this first phase of development, there is a sort of space that is shared by baby and mother. And of course, all the theory of mirror neurons, all the theories of the origin of this system that matches what we observe with what we do, and all the theories about embodied cognition are kind of in keeping with this idea. And one thing is sure, is actually absolutely constant in these dyads, and that is when you have brain damage or you have a difficult birth, this dyad is disrupted. Is disrupted because the baby is not able to produce signals in a reliable way, because he's brain damaged, he's not able to capture signals in a reliable way. But if we think about it, the same applies to the mother or the caregiver, who are traumatized, are not able to read the signals, are frustrated by this, have a lot of uncertainty about the future, usually have also a mental health vulnerabilities related to a process that went very different from what they thought. So this is the space where we think intervention should occur. And of course, there are many studies that support this hypothesis. I'd like to just quote one of the most recent ones, in which it was shown in normal babies that even if when they interact with their caregivers and they have contingent interactions and contingent relations, even if these interactions are not very frequent in absolute terms, you can see 1.52 per minute of contingent responses between and dialogue sort of between mom and baby. Babies from a very early stage of development are able to capitalize on this interconnection, in this intersubjectivity, these moments, even if they're not very many. Infants are really building on those in terms of cognitive development and social development. So we really think that there is enough evidence to believe that if we are able to take care of this intersubjective moment in this we space and all the elements that compose the we space, we're really probably likely to affect the natural histories of these babies and their mothers and fathers. Having this background in mind, so having the possibility to early detect, having the knowledge that this is an important problem, having the knowledge that we have at least a neuroscientifically sound way to address the early intervention issue, we developed a model of intervention, and then we transferred into a project and a proposal. And in this model, as you can see here, the final goal is intersubjectivity. So we have, as a target, we have mom, we have baby, we have the environment. But in all cases, our real goal is to impact on these moments of intersubjectivity on to which the baby is able to capitalize for his or her development. And so we want to take care of the caregiver, for example. So we give family support, partner support, self-care. We want to know what are the psychological consequences of this difficult journey in mothers and fathers, and we try to address that. We want to address that. We want to put that in the center of our intervention. Of course, we want to have the baby available for these exchanges, relational exchanges, and so we want to manage pain. That is, this age is very, very important and frequent. Sleep hygiene, visual correction, and we'll come to that, and contain posture. So, and of course, controlling seizures or any other comorbidities, with the final goal of making the baby available for this such an important building block of development that is intersubjectivity. And of course, we want to target the environment to make it so facilitating for the baby and mothers that these moments can actually be facilitated. So having this in mind, we developed a protocol in infants that are particularly compromised in their development, those that have brain damage, that are at high risk of developing a cerebral palsy, but also that have visual problems of central origin. We know that when you have a very severe diffuse lesion, it's the rule rather than the exception to have a visual problem of central origin, because we know how a lot of the brain is actually devoted to visual processing directly or indirectly. And so we know that to some extent having a severe brain damage implies having a severe or a cerebral visual impairment to some extent. So this severe population was the target of our study, and is the target of our study. Also because it's a population that is quite neglected by other projects. In many studies, people tend to exclude those severe ones because they are kind of, first of all, it's hard to make a change in their histories, and also they kind of skew the population towards severe ones, and so they kind of introduce variables that are very hard to manage. But in this case, we really wanted to target them. And so we developed this protocol that I'll tell you about, and we thought of Cerebral Palsy Alliance as one of the possible recipients for our project, because CP Alliance is currently a very, it's a body of funding that likes very much also very new and sort of high-risk research, clinical research in cerebral palsy. They have funded a lot of projects that kind of have a strong base, but also are very innovative. So for this reason, it is not sure that they're going to work. Some weeks ago, there was the ACD in Paris, and I remember Bernadette Gillig talking about Cerebral Palsy Alliance as the first agency giving her some money to develop her TDCS protocol, that it was very innovative, very sort of high risk in terms of potential results. And it was very interesting to apply there and to be able to create a network that has the center in Italy. We are the PIs of this project, but has most of the recruiting centers, 4 out of 5 in Australia actually. And so it's an interesting model, because we are sort of the ones who developed it and who have the experience so far, but we want to apply it in a system that is probably much more uniform in terms of what are the things that can be done in this field, especially because there is not a lot of experience in this specific field of severe cerebral visual impairment yet in Australia. And so it's a good way to try to start a project. And in Pisa, since we have a model that is already applied, we are unable ethically to run a randomized control trial of this kind. And so we had to have as the Italian center a center that is in southern Italy, Naples, where this model is not standard care. And so this is also very important, because to make things ethical, you cannot start depriving your patients of something you currently do because of a randomized control trial. And if we think of the broad aims of this study, it is important to state that we wanted to, the main aim was to determine feasibility and acceptability. So this is also something that could be of interest to you if you are thinking of doing or running a study on early intervention. The first thing, of course, is to determine feasibility and acceptability. And this is also important because it allows you to have a limited number of patients. So if if this is your goal, you don't have to reach the very high numbers that are required for an RCT that is actually testing an intervention. But we use this model that has been used also in previous studies, for example, in the GAME project, of having this as our first aim, but having a second aim that is actually evaluating efficacy of the visible program. So it's this is the reason why we are actually doing a randomized control trial, because we also want to see, even if in a small number, to see whether we are kind of impacting on some measures of improvement in visual function, developmental outcomes, and parent-infant emotional and relational development. As I said, this model will follow also by the GAME study, the GAME protocol, for example. They did a study some years ago in which we were involved peripherally, and they found in a small group of babies that were randomized, they found good feasibility, acceptability, and initial evidence of efficacy. And that those results have triggered a much bigger RCT that is now running in Australia. And so this was what we had in mind. So even if it's a small, even if it's a pilot study, even if your main goal is feasibility, it's a good idea to do a randomized control trial to have pilot evidence of the effects of the training. And so we did our clinical assessment randomization, and then we have our standard of care and our visible. And then we have pre-post assessments. I'll quickly go through those in a second. So as I said, it is very important for this kind of study to have good eligibility measures that make your population really at risk. You don't want to have a diluted kind of cohort, and at the end of your study have high percentages of babies that actually do not develop a cerebral palsy, because that probably means not that you did a good intervention, but that probably you selected poorly your cohort. And so, as I said, we use the guidelines, and the guidelines say that we can put a diagnosis of very high risk of CP if we have abnormal GMs or HINE at 3 months, or the GMs, or after 3 months the HINE, then if we have an MRI that is compatible with cerebral palsy. And this is also very important. And also, of course, we need the vision criterion, and that's having a performance below 2 standard deviations with great angle acuity. This is what we picked. Exclusion criteria here are pretty standard. Of course, if you have drug-resistant epilepsy, if you have anatomical malformations preventing any vision, like bilateral ophthalmia or microphthalmia, if you have infants with a medical fragility preventing the ability to participate, these are major exclusion criteria that cannot be overcome. So the vision was also very, very important. Oh, you don't hear me. You should have told me earlier. Shall I start from the beginning? So the vision is very important. So what we do, we use a flow to be sure that these children, these babies actually have a low vision. And of course, this is a very kind of difficult call to make. Or if you wish, it's virtually impossible to make a diagnosis of CVI at 3 months, because CVI is by definition something related to cerebral vision impairment, cerebral processes, and we know that before 3 months, most of the visual behavior that we can test are basically subcortical, are not really involving too much the cortex. But still, we needed to have something that could give us an early recruitment of these babies. We cannot wait 6 months to start intervention, so we went for this kind of criterion. And then we defined some general principles of of our intervention. And the most important is, of course, visual adaptation. So the main kind of strategy we had in our visible intervention was providing a visual facilitation to infant through the adaptation of the environment. So the therapist is asked to go through the essential aspects of visual modification of the environment with parents, and together with parents they identify the most suitable activities to allow infant successful engagement with the social and physical environment during both play and targeted developmental activities. So the parents and families are really involved from the beginning, because they are the one who have to come up with the goals and have to come up with the strategies with the support of the therapist that is kind of next to them, trying to facilitate this process of setting goals and setting strategies. And these are just a number of examples of how you can modify the environment to make it more salient for your baby that is not actually seeing normally. And so you can adapt, of course, the light, you can change the brightness, you can increase the contrast of the objects. You can find the best movement speed for the baby to capture the stimuli. You want to be consistent in the environment so that the baby doesn't have to process every minute a changing environment, but kind of knows what are the limits and what are the things surrounding him or her, and so can focus on the intersubjectivity. Of course, the salience of the environment need to be adjusted, and also you can take advantage of multimodality, multisensoriality. So this is a list of things that contains a lot of different ideas and activities. There are many other principles. I'm not going to through all of them, but one I want to underline is the role of the therapist. So the role of the study therapist is support the parent in each phase of the intervention. So it's mainly to support parents, and the direct therapist child interactions are meant to demonstrate to the parent the various aspects of the intervention activities rather than to directly treat the infant. So it's a sort of hand-off kind of treatment. It's not the therapist that is treating, but is the therapist that is helping parents to understand or together to understand what are the possible strategies that can be effective. And then therapy is driven by infant availability, of course, and so part of the project is to explain and to reinforce parents on their abilities to understand when the infant is available, and then controlling for other aspects of sensory function, like through, for example, a good positioning, parent comfort. Parent also needs to be comfortable during these activities, because otherwise the performance of the parent will not be good enough to trigger a good intersubjectivity. Some of the rules, like give infant time, praise, contingency and praise. Anyway, these are general principles, but the two main phases we identified, this is a project that goes on for the first year of life, is the phase of dyadic interaction, which we really focus on the space between mom and baby, and the environmental exploration, which is a phase that kind of appears a little bit later, when the baby is kind of able to rely on what he has learned in this first phase to explore the environment. So the goals of this first phase is to increase quantitatively, improve qualitatively the opportunities of positive dyadic interaction between baby and adult. And in the second phase, we want to maintain this secure relationship, layering on parental facilitation of the infant's growing awareness of the wider environment. So there's not, there's a big overlap. There's a big, it's not that phase 2 is replacing phase 1, but it's actually layering on phase 1. And the reason why these periods are kind of kind of vague in terms of months is because, of course, every baby, especially those with brain damage and big problems in early development, will have their own kind of pace. Of course, it's very important in this case, since the therapy is provided at home, to provide the parents with some tools that they can easily access to and kind of read and learn from. And so we also developed a activity booklet for parents. And one of the things we tell parents is put your own mask first. What we kind of, in analogy with what is said in airplanes when you start flying, and the flight attendant tells you to put your own mask first and then look after your child, which sounds very kind of, how can I say, it's kind of not spontaneous in mothers and fathers, but this is very important for us, for them to understand that their health and their mental health, their availability as caregivers is very important for the intervention to have success. And of course, we have a lot of activities that can be shown. Another tool that we use in this project is an app that is called My Cup, that you might know is an app related to the Red Cup kind of database and the projects. And you can actually design your app specifically for a certain project. Mom and dad can download it for free. They can just connect to the project they are in, and you can do all these things. You can synchronize with RECA project, of course. You can add project participants, create tasks for the families, create active tasks, assign tasks to participants, scheduling and sending messages, announcements, and so you have a direct connection with and very easy with parents. It's free, as I said, and it's really secure as a system because it's really individualized and secure. So to finish up, of course, what are we trying to see? What aspects of development we're trying to change with this project? Of course, we're trying to change the vision because it's a project on vision, but this is not actually the main goal. We think that vision at this age, the improvement of vision, and this is an infant battery that we developed for this project, the improvement of visions are kind of will go together with all the other improvements in neurodevelopment, but of course is a target. But also the other, there are a number of other measures that we want to assess. I'll just show you very quickly to kind of show you what are the domains that we are interested in. Of course, visual acuity is said. Of course, neuroimaging. We want to see whether this intervention has changed the connectomics and the connections between in salient areas between the two groups. Of course, we will do GMs and ophthalmological exam, and this is kind of a baseline and neurological assessment for the baseline. But then we also use parent questionnaires, videos of parent-child interaction, semi-structured parent interview, COBM, I know you talked about this today, and of course motor and developmental scales. So we try to target parents and parents' mental health, try to target their way of seeing the improvements in the babies because they are the ones setting the goals, and of course also visual and more global development in our babies. And I think this was my last slide. So as I said, we started from the idea, wrote the proposal, got a funding agency that was interested, got the money, and now we are starting the project. and hopefully in a couple of years we will have some results. And if things go as we have planned, that we will have some initial evidence of a effect of this intervention. Of course, the next step will be to apply for a larger cohort study, larger randomized control study, to see actually in a larger group of babies if this is a feasible and effective intervention more in general. These are some of the people that were involved in developing this study. Not all here, but this is some of the most relevant ones. And I think this is my last slide. I don't know how long it took to present this data, probably half an hour. So if you have any questions or if you're not too tired, yes.
Yeah, the question is, I didn't really get it, but the intervention and the therapist intervention, helping the parents to accommodate like the environment and helping them with their needs for their self-care, like how big, like how much time do the parent have with the therapist, and is it the same therapist or is it different therapist? There was.
Yeah, sure. I didn't go too much into the details of the protocol because I was more interested in telling you the general frame. But so this is the protocol is made so that basically therapists go to babies' homes once every 15 days, and they so every 2 weeks, every fortnight, and they have It's not said how much time they will stay. We think it's going to be, of course, all these things will be mapped and controlled for, but it's probably around 1 hour, 1 hour and a half, depending on what are the questions that are raised and how complex is the situation and how the parents are kind of understanding the idea. And of course at the beginning we expect to have longer meetings and then probably shorter ones, and so the idea is not that the dose is actually what is done in that hour, but the idea is that actually the therapy is delivered by the parents, and so we keep track of that. And we will see how this is correlated with the effect.
Thank you for the presentation. I followed your presentation also in Paris, and some presentations of your group, and it's something that came to my mind at that moment, and I didn't ask at that moment, so I think this is a good moment for me. Every time that you speak about this first moment, and that the intervention is focused in not only in the baby but also in the relation and the interaction with the mother or the father, comes to my mind the word attachment. And I was thinking if you have considered, or maybe in a future a follow-up of the study, to include maybe some measures of attachment between parents and the baby, and also going further, and this is maybe crazy, but maybe to consider some measures of social cognition, such as emotion recognition, facial emotion recognition, or theory of mind, or things like that. Maybe relating this with autism treats. Well, just that. Thank you.
No, that's absolutely very interesting, and it's a very sensible common and sensible thing to do. We are not. When you do these kind of studies, you have to pick some some items and some tools, and of course there are tools that are more directed onto the attachment kind of paradigm. We're not using those so far. I want to say also, however, that this study is a study that is meant to last basically overall 3 years, but the baby are followed from birth to 1 year because of needing to give some feedback. But of course we will keep following them. Hopefully we'll have fundings and resources to do that. And so higher kind of order outcome measures will be certainly interesting to be used. So it's just a minimum set of tools that we wanted to explore, kind of to try to have everything under control. But hopefully we will be able to follow these babies more.
Thank you.
Okay, so we move on.